Buongiorno intanto, mi
Good morning. I too would like to congratulate Vittorio Agnoletto because I know how much work he put into this initiative, which most certainly wasn't easy to organize and to coordinate. I've been asked not to go over time. I think, however, that we can start speaking about the two presentations that will be held during this session, and I would like to call um, Professor Paolo Cavalli, who is going to present some slides, and being an oncologist, as Vittorio Agnoletto was saying earlier on, there are some scientists who do not wish to subordinate their studies and their science to the design of capital, especially financial capital and liberalism and the free market, but they should devote their activity to what is going on in the world. Franco Cavalli, certainly in the world, in the world, in the sense of healthcare for people. Franco Cavalli is often told that he has some sort of orientation. In actual fact, he has put together his medical, his political, and his scientific and his family interests all together. So let's say that this man is most certainly one of those important persons that Agnoletto told us a while ago that we should really listen to. Good morning, and thank you very much for this presentation. Very generous indeed. I thank my friend Vittorio Agnoletto for the invitation. Although the topic that he asked me to speak about, that is to say, to speak about the determinant factors of cancer today, is something that is very difficult to discuss. Not because when we speak about cancer, we're speaking about 200 different diseases, but despite the fact that we know a lot about the genic anomalies and cancer, we know very little about the correlation between the social system and cancer, and that is because there is no finance for this sort of studies. Most certainly not the pharmaceutical companies which finance 100% of clinical studies, but not even the agencies that finance some of these studies are not putting in as much money as we need. I don't know what I should do to get the first slide on the screen. Bear with me a moment, and I think that we should have it quite soon. Okay, this is the introductory one. This is the one I wanted. This gives you a situation of 2012 at the worldwide level, when there were 49.1, 8.2, 14.1 million new cases, 8.2 million deaths. You can see the most common ones at the global level. I would like to draw your attention on the fact that 50% of new cases and 60% of deaths were in the so-called transition countries, which are the poor countries in a certain way. In 2030, 3/4 of cancer deaths will occur in the poorer countries. This slide, which refers to 2015, shows you the frequency of the various causes of death of people younger than 70 years of age. Cancer is equivalent to deaths due to infections, a little bit lower than those due to cardiovascular diseases, although this refers to the population younger than 70, as I said. If we look at the whole population at the global level, cancer has become the greatest cause of death. And even for people who are younger than 70, which are called premature deaths, will probably occur in the next 2 years. In order to understand why there will be a greater impact of cancer, we have to see what the situation at the worldwide level is today. And you can see that cancer is in the first place in the richest countries, while infections are still in the first position in the poorer countries, although in Africa 1/3 of cancers is linked to infections, and therefore they are slowly growing up, rising above the level of infections. Before 2012, there were 14 million new cases, and it probably just for the population evolution between 2025 we will have 23 million new cases, and these are forecasts of the World Health Organization in terms of healthcare. However, if we consider the increase of risk, and all the forecasts say that by 2035 there will be globally, but especially in the poorer countries, an increase in the risk of having cancer. You have to add 5 million new cases, and every extra percent point corresponds to 5 million cases more. And this is what happened in rich Europe between 1970 and 1990. This is a complex theme because we have to do with a lot of diseases. However, they become manifest differently according to the latitudes. Here you can see which are the most frequent cases for the female population. You can see that in Europe, United States and Australia, it is lung cancer. In the transition or poor countries, it is breast cancer, or in the poorer ones still, it is the neck of the uterus, which in our countries is becoming a form of cancer with a very low mortality rate. To make you understand even more, in Mongolia, half of the cases of cancer are liver cancers due to hepatitis, for example. In the Andes, for example, gallbladder cancers connected to the environmental situation are among the highest. So it's very difficult to make different calculations because things are moving rather rapidly. Now, apart from human suffering, the economic impact that neoplasias or cancer have, we can see that in Europe, the impact is almost 0.7% of the GDP per year. And this loss would not even be there if we did not have these diseases. And let me explain why. Until a few years ago, the World Bank wasn't even interested in cancer, but now considering the high importance that cancer has in economics, the World Bank is also taking an interest in this. This slide shows you what happened in the last 40 years in Western Europe. In the countries of Western Europe and in part of the United States, unless we consider the poorer part of the United States, there was a small decrease in deaths due to cancer. And if we see why this happened, these are British data, but most certainly they can apply to the rest of Western Europe. And here too, they refer to the population under 70 years of age. For the others, there is a completely different category of cancer. Also, because the environmental impact is something that has to be considered very well, because a newborn who already has a cancer cannot be considered someone who is affected by the pollution in the air, for example. You can see here that the main causes in the recent decades have lung, smoking, colorectal, treatment and screening, the stomach, unknown. As far as lung smoking is concerned, the fact that there is less smoking. If we think of colorectal, it is due perhaps to the fact that we eat better, fewer fats and so on. But the uterus, because of the screening, the regular screening, and both for the neck of the uterus and also for the improvement of hygiene conditions. And the same thing applies to the stomach. Now, these two slides tells us something very important that Vittorio had already mentioned. This slight drop in mortality in the wealthy countries is due essentially to prevention. For example, the drop in the number of smokers and in the drop in the incidence of uterus cancer and also breast cancer. But only marginally these are due to treatments and therapies, along with early diagnosis. Treatment has been very effective, but especially in the case of breast cancer. But for the others, the improvement has been in better and more frequent prevention and early diagnosis. This does not happen in the poorer world. There's an explosion of cancer in these countries, because here we have the sum essentially of poverty-related tumors, cervical, esophagus, liver, and increasingly more also tumors linked to the Western style of life: breast, lung, prostate, and colorectal. There are some economists that take these data, and when they see that, for example, there is a decrease in breast or lung cancer as an improvement in the way of life, but in actual fact it's not. It's simply the adoption of a Western style of life. Just think that 97% of anti-cancer drugs are used in Europe, United States, and Japan. And the countries that already today suffer from 75% of cancer in the world only have 25% of anti-tumor drugs. This also explains the fact there are almost 40% of countries in the world that there is no radiotherapy machine. They don't have one radiotherapy machine, while in other countries there are 300 or 400. So today we are able to cure 70-75% of breast cancer after a 5-year survival period. Now, if cancer increases in these countries, despite the fact that there may be an improvement in healthcare, the number of deaths goes up, paradoxically. In Lugano, in the European Oncology Conference, we came to the understanding that if nothing changes in terms of the investments that are made, we will lose this fight. Now, as far as the subject that was assigned to me more specifically, I'll bring a couple of figures to you. According to the National Healthcare Agency in France, industrial workers, only 50% of cases of cancer is due to smoking. In rich Switzerland, there is a trend to two-speed medicine for the wealthier and for the less wealthier. In the Geneva Canton 2015, the Register of Cancer showed that the 20% richer population had a life expectancy that was double the people who had the same cancer but belonged to the 20% of the poorer population. Data of the American agency showed how the mortality of the Afro-American and Hispanic population is on average 30% higher than the Caucasian whites' death for cancer. Vittorio has already given you some of the data, but between 1990 and 2010, the Russian population, due to the incredible chaos that there was in the healthcare system, they have lost 7 years of life expectancy. Before 1990, today, in other words, the transformation of Russia had given the people 1 year increase in life. As far as worldwide data are concerned, we know that obesity is an important element in the arousal of cancer. It's becoming even higher than smoking, for example, in the United States. It is considered that in the world there are 460 adults who are obese, and that 9 to 10% of cancer in women is related to obesity. There are some types of tumor where this is more evident, for example, the endometrium, the esophagus, renal, and liver tumors. And if we look at the United States, there is a clear predominance in the poorer populations because they don't eat well. They eat at McDonald's, for example, compared to those with a healthier diet.
This is the latest edition of the European Code against cancer, for the prevention of cancer, that was established a couple of years ago, and it was accepted last year by the European Commission. It is based on individual prevention to a large extent. However, there are a few important general factors apart from smoke. By the way, in poor countries, by smoking, we don't mean only individual smoking, but also smoking in homes, which very often leads to cancer. But obesity plays a big role, of course, and healthy nutrition, and also avoidance. A number of factors based upon document produced by the Lyon agency on cancer factors in the workplace. Radon, for instance. After tobacco, the major cause for cancer is radon, which here in the West accounts for 8% of lung cancers. And also the need to guarantee early screening for cancers, and this is possible nowadays, especially for large intestine cancer, breast cancer, and cervix cancer. I'm about to conclude now, and we will have time to discuss about these topics later, on something that Vittorio mentioned earlier, which is gaining even more importance, namely, on the one hand, the huge increase of anti-cancer drugs. The new drugs being put on the market cost 170,000 euro per year per patient, and very often combinations of these drugs are used. Therefore, we expect that in the short run we will have treatment costing $500,000 per patient per year. New studies recently came out on these problems. Some oncologists are publishing letters on newspapers, as it was the case in France and the US, saying that we need to change this. As you probably know, pharma industry have huge profits, even bigger than other industries, possibly with the single exception of the military. If you look at big monopolies, they have profits amounting to 15-16 billion per year. So to sum up, in the past 25 years, the cost for drugs, cancer drugs, has increased by 40-50%. And the treatment outcomes haven't improved at the same time. There are studies proving that there is no correlation between the cost and the effectiveness of the drug. Of course, the costs vary from country to country. Something very important that we should consider, that Vittorio also mentioned, is that WHO has finally set up a committee, that I'm a member myself, starting to set up a list of essential drugs. These drugs should be available in all countries, and the fact that a drug is considered as essential is very important. Because, as Vittorio was suggesting at the beginning, according to Doha Agreement, if a drug is considered as essential, there is a right to use generic drugs if they exist, and not only patented drugs. This is very difficult to implement. Lula was managed to do something about that, and one of the reasons why he's been so criticized. And Colombia's government, for instance, recently wanted to consider a drug produced by Novartis for treating chronic leukemia as essential. This would have allowed the government to use the generic drug produced in India, although the drug is presently still under patent. Novartis wrote a document to the Colombia's government saying, if you do this, we will cut all aids for development. So this is what happens in the relationship between monopolies and governments. But there is even worse than that. Data are being published right now, very clear data showing that the majority of these drugs, very expensive drugs, that are advertised by journalists, paid by pharmaceutical companies, or also by large groups of patients, also paid by monopolies. Data show that they are not very effective. It has been proved that 57% of anti-cancer drugs approved by EMEA that we're fighting for right now in Milan, to have it located in Milan, are of marginal or no utility as regards prolongation of life and or improvement of quality of life for patients. Now, the study took into account not only clinical studies funded by the industry, but also all data have been gathered during time on ordinary patients, because in studies nowadays only a selection of patients are included, and not ordinary patients that we treat on a daily basis. 10 days ago, we organized in Switzerland a forum with experts discussing this situation. And Mr. Tito Foyo, working for the U.S. agency, and now in charge of the clinical trial unit at the Columbia University in New York, so someone very authoritative, he provided data. According to him, 62% of drugs accepted between 2006 and 2016 by the U.S. administration are either useless or of marginal utility. There are drugs that have been accepted on the market costing $5,000 per month, just because the clinical study provided for a 12 days of survival increase for patients. So I will conclude with something that can serve as hope. The only country in the world experiencing a huge increase of welfare and the healthcare expenditure right now is China. And this is because President Xi Jinping has decided, as it was also written in The Lancet in 2016, that all governments should consider healthcare. This is why they are renationalizing hospitals that have been previously privatized, and an expansion of public healthcare expenditure. You might be familiar with this new initiative, the Chinese Belt and Road Initiative. Next weekend I will be in Beijing. I have been invited by Dr. Shen Zhu, former Chinese health minister, an important oncologist who discovered that a treatment, a cure for a form of leukemia through vitamin A. And although he wasn't a member of the Chinese party, while he was served as a minister, he has organized a conference to see what can be done through this new Chinese Belt and Road Initiative to face at a global level, to tackle cancer at a global level. So I won't show you the last slide, but I will conclude by showing you this sun that Vittorio also showed you, maybe indicating what's new, what's coming from the east. Thank you.
Allora, ringraziamo.
We would like to thank Professor Cavalli very much. And I've just been told that if you do not already have provided yourselves with your headsets to listen to the translation, you should go and get one. That is, if you need translation, because Dr. Roberts will be speaking in English. There are some of the presentations of Dr. Cavalli that really impressed me, that there is such a great disproportion between the wealthy countries and our countries, and the poorer countries. But another thing that really struck me was that this difference between the poor and the rich countries is that within the rich countries there are poor and wealthy areas. And these are not really surrogates. There are studies that document the condition of poverty and subordination, social subordination for that reason. In the production system, in the social life, social everyday life, in being a factor of disease. And we all know that those who cannot study, who are poor, cannot study. The fact of being poor, of being subordinate, of not having any kind of independence in their existence is by itself a cause of disease. Now, physicians that say this are said to be oriented to the left. Firkov used to say this before he became one of the great members of pathology in general. If a scientist, a physician, a researcher really has interests in the core of his or her study and research, they can, but have to recognize how social injustice is a cause of disease. And here, of course, the problem that comes into cause is a problem of drugs, of pharmaceutical products. Scientific publications are the arm of the pharmaceutical companies. I've already mentioned Lancet, and there are others. And of course, all of these publish at times of the types that have already been said. Drugs, for example, that from a statistical point of view are more effective than others, but then if you go and look at the survival rate, it's down to 12 days or a month or two. So it is a system which, in its complex scientific communication, scientific research, and which is not at all sustainable anymore. So we need to go over these things, see what happens. And they all point to one thing: class interest. And the same result comes out no matter which way you look at the issue. Now, Matthew Roberts is part of an international group which is fighting in particular for a problem, but of course he has others. He is now in the process of graduating, and he will be a psychiatrist. And I think that Professor Cavalli also started out by wanting to be a psychiatrist and then became an oncologist. However, Matthew Roberts will now speak to us about the initiatives of the UAEM, Association for Essential Medicines. In Italy, for example, people say, let's give everybody an essential level of healthcare. But if they were really essential, that would be a good thing. Very often behind this idea, there's an issue of reducing the intervention of the public sector to the advantage of the private one.
Right, thank you very much. And I apologise for being a very stereotypical Brit and speaking in English. Could I possibly get my slides on the screen? Thank you. So my name is Matt Roberts, and I'm one of the European coordinators for Universities Allied for Essential Medicines. UAIM, which is the shortened form of Universities Allied for Essential Medicines, is an international student organisation that campaigns around the world in various different ways for access to medicines. So we're active at various different levels. We campaign at the university level, trying to change the way in which universities conduct research and license their research. We're active at national levels, trying to influence policy processes that relate to access to medicines. And we've also been active in international fora, like the EU, the UN, and the WHO. What I wanted to talk about in the next kind of few minutes is sort of the background to the access crisis. And I apologize if some of what I say has already been mentioned, and to those who may already be familiar with it, if I'm telling you what you already know. Then after that, I want to just propose a few of the solutions that we at UAIM, as well as our allies in the access community, believe are important in addressing these problems. So first of all, what is the access crisis? Part of the access crisis is what we call the access gap. So this describes the fact that, on the one hand, 1/3 of all people in the developing world don't have affordable access to medicines that could save their lives. Now, this is a really massive issue. It's been estimated that around 10 million people die every year just because they can't get access to medicines that already exist. So we have the treatments that can cure these illnesses, but the people who need them the most aren't getting access to them. To put these numbers into context, the kind of highest estimates of the number of people who die as a direct result of conflict every year are less than 500,000. So the access crisis kills more people every year than every war on the planet combined. And in the majority of cases, the reason why people can't get access to medicines is because the medicines are priced too highly. Too highly either for themselves to afford or too highly for their national governments to afford. And in most cases, the reason why these drugs are priced so highly is because a single pharmaceutical company will have the patent monopoly over that drug, meaning it can set whatever price it likes. And the price that it will set will be the one that maximizes profit, not the one that maximizes health. So that alone would be a massive crisis. It would be an outrage. But it isn't the only problem, because this only refers to illnesses for which we already have effective treatments. And there are many illnesses for which we don't really have any effective treatments, and these are neglected diseases. 1 in 6 people in the world suffer from a neglected disease. And the people who suffer from these illnesses are generally the poorest of the world, people living in lower and middle income settings. And that really is the crux of why they are neglected. Because the people who suffer from these illnesses are too poor to provide a market for new medicines, there is no profit incentive for doing research into these illnesses, so very little research takes place and very few drugs are produced. To give you an idea of kind of the scale of this problem, across a 29-year period in which almost 1,600 drugs were created, only 21 drugs were made for these illnesses. In fact, this is probably an overestimate because it includes TB and malaria, which aren't, strictly speaking, neglected diseases. If we remove those diseases, only 10 drugs were made. That's 0.64% of all of the drugs that were made in that period. If you compare that to the 1/6 of the world's population who suffer from these illnesses, you can see the really massive disparity between the burden of illness and the amount of research focus that they receive. So these two problems, the research gap and the access gap, are really at the core of the access crisis. And as you can probably already see, they both stem from the same problem. That is, that our current research and development system is orientated towards maximizing profit, not towards maximizing health. It's also important to note, however, that this is no longer a problem that is confined to lower and middle income countries. This access crisis is expanding, and higher income countries in Europe and in North America are now also facing the strain. So there have been several examples that kind of illustrate this, and I just want to go through a few of them now. So the most famous of these is sofosbuvir, which we've already heard a bit about today. Sofosbuvir is a very effective hepatitis C medicine. However, in the United States, a single 12-week course of sofosbuvir for a single patient costs $84,000. In the UK, it costs the equivalent of $53,000. The company that manufactures sofosbuvir, Gilead, has in just 3.5 years made over $34 billion on the sale of hepatitis C medicines in the US alone. More recently, we've had the case of Orkambi. Orkambi is a cystic fibrosis medicine. Belgium and the Netherlands recently had to decide to not offer Orkambi in their national health system because the price that was demanded by the manufacturers was simply too high for those countries to afford. Now, this example becomes more outrageous when you realize that the research into Orkambi was almost entirely financed through charitable money, and almost all of the clinical trials for Orkambi took place in a publicly funded university hospital. And yet the company that manufactures Orkambi, Vertex, charges around $259,000 per year per patient for this drug in the US. In the UK, we've had the case of Ibrance and Zytiga. These are both cancer drugs, and again, they were both developed with publicly funded research money. However, they've been priced so highly that the UK National Health System has either had to not offer these drugs in the NHS or very strictly limit the number of patients who can have access to them. And then finally, most recently, we've had the case of Lucentis. So Lucentis is a treatment for wet macular degeneration. That's the most common cause of blindness in the world. The same manufacturers of Lucentis also manufacture a drug called Avastin. It's a nearly identical drug, but that drug is licensed for the treatment of cancer. Now, Avastin has been demonstrated to be safe and effective in treating macular degeneration, and it would also cost 10 times less than Lucentis. However, the company that manufactures both of these drugs has refused to license Lucentis for the use in Avastin, for the treatment of macular degeneration, so that it continue charging high prices for Lucentis. And when the NHS proposed to use Avastin off license at a much cheaper price than Lucentis, the drug company threatened the NHS with a very significant lawsuit, and that is still an issue that is kind of up in the air. So these kind of examples really illustrate the fact that this access crisis is now something that affects every country in the world. It is an increasingly serious problem. But it's also worth pointing out that the R&D system as we currently have it is not just failing to deliver affordable medicines, it's also failing to really deliver new medicines. So most of the new medicines that we have, the so-called new medicines that we have, are in fact what we tend to call Me Too drugs. They're minor modifications in the structure or delivery of an existing medicine. So for example, you take a medicine that already exists, you change the way that it's delivered to a patient, so you maybe change the inhaler or the injection device, or you add a methyl group onto the structure. It's essentially the same medicine, but you can get a new patent on that drug and continue charging exceedingly high prices for it. We've already seen some examples of that from various different presentations, but from 1989 to 2000, 65% of new drugs that were approved by the US FDA contained active ingredients that were already available on the market. So they were essentially not new medicines at all. More recently, the organization Prescrire has analyzed new medicines that were approved by the European Medicines Agency in 2016. You probably can't quite make out the numbers here, but this 5% here is medicines that the prescriber have sort of withheld judgment on. But this 17% and 61%, most of the chart, those are medicines which are not an improvement at all on medicines which already exist. So these so-called new medicines, the bulk of them are all Me Too drugs. They are not new at all. This 10% here are possibly helpful, and only this 6% of new medicines actually offer any real definite improvement over the medicines that we already have. And it's important to note that these new medicines, because they will be patented from the start of the patenting process, will be more expensive than the medicines that we already have on the market. So not only is the R&D system failing to deliver affordable medicines, it is failing to deliver new medicines as well. At this point, it's probably good to get some context. So there are a few points to mention here. The first is that medicines are actually exceedingly cheap to manufacture. To physically produce a physical drug, the cost of that is minuscule. And the cost of manufacturing a medicine is completely unrelated to the price at which they are sold. The flip side of that, the other side of the coin, is that the pharmaceutical industry has consistently refused to release data on how much it costs to research and develop a drug. In the face of significant demands for them to do so, they have consistently refused to actually release that data. And I'm going to come back to that point a bit later on because it's very important. It's also worth reminding ourselves, as we already have done today, that the pharmaceutical industry is the most profitable industry in the world, with the possible exception of the military industry. The pharmaceutical industry has 19% profit margins. Those are huge profit margins. The pharmaceutical industry is also the industry that spends the most on lobbying of any industry. So we hear a lot about the gun lobby in America, but their spending is absolutely dwarfed by the spending of the pharmaceutical sector. 9 out of 10 of the largest pharmaceutical companies spend more on marketing and lobbying than they do on R&D. So, that's quite a few problems that I've highlighted, and I want to now focus a bit more on what we think can be done in the short term and the long term to help address some of these issues. But just before I go on, I think it's always worth just reiterating the fact that all of these problems all stem from the same problem, and that is the R&D system as it currently stands is not fit for purpose. It is not orientated towards the patient interests, it is orientated towards the interests of companies. And that is the real problem that we're grappling with. So, what do we at UAIM and what do our many allies in the access to medicines field believe can be done for these solutions? Well, one of the areas in which there can be improvement is the inclusion of global access provisions within research and development. So particularly when research and development is funded through public money, we believe a condition of receiving public money should be the inclusion of provisions and conditions which guarantee access to medicines. Now, we believe that these conditions should actually be included in all R&D, in all research and development. But hopefully a quick and easy first step would be to make them a condition of receiving public money. So the most basic level of this, I suppose, are comprehensive access strategies. So we believe that publicly funded research and development should include formal strategies for ensuring access to medical products. These strategies should consider all of the potential barriers to access and include comprehensive strategies for how these barriers are going to be overcome. So essentially, if you are working on developing a new medicine, you should have, and as a condition of receiving public money, you should have included strategies into how you are going to make sure that this medicine will be accessible to as many people as possible. We also push for responsible patenting. So wherever possible, we believe that the end product of pharmaceutical R&D should not be patented. It should be available as a public good. However, where patenting is necessary, either to guarantee access, guarantee that the medicine reaches the market, or to prevent patenting by hostile third parties, we believe that these intellectual property rights should be proactively managed in order to maintain access. So in other words, the purpose of intellectual property should always be to maximize access and never to maximize profit at the expense of access. And again, these sorts of conditions should be conditions of receiving public money. It's also worth pointing out at this point that generic production of medicines is one of the most effective strategies that we currently have for reducing the price of medicines. So generic production, for those who might not be familiar with the term, is when multiple different companies all sort of produce copies of the same drug. And that's been demonstrated time and time again to push the price of that medicine down. So one example of this is stavudine. So stavudine was an HIV/AIDS drug. It's not used much anymore, but at the time it was quite revolutionary. and generic production of stavudine reduced the price of that drug by 30 times. So it massively increased affordability, and it massively increased the number of people who had access to that, at the time, life-saving medicine. The other side of global access is open access policies. So we believe that all R&D should include policies that third parties should have the right to access publicly funded research and the right to use the discoveries of publicly funded research. And central to this is the idea that the principles of open science and data sharing are essential to any effective R&D system. So we're not just trying to address the affordability of medicines here, we're also trying to address the fact that I mentioned earlier, that our current R&D system is not really that innovative. And open science and data sharing between different research teams are crucial to improving on that system. The next area is transparency. So there are various different elements to transparency that we need to push for improvement on. The first of these is transparency of drug prices. So what's often quite surprising is that we simply don't know how much different countries are paying for their medicines. In fact, different countries don't know how much other countries are paying for their medicines. And this isn't an accident, this is an intentional strategy, because it allows pharmaceutical companies to charge more for their medicines. So for example, if the United Kingdom doesn't know how much the Netherlands are paying for their medicine, then they will have, or rather if they do know how much the Netherlands are paying for their medicine, they will have a stronger negotiating position and might be able to get a cheaper price for that medicine. So the pharmaceutical industry makes sure that these prices are kept fairly transparent. So on the one hand, the publication of these prices publicly, making them publicly available, would facilitate advocacy, it would improve accountability, and it would allow us as advocates in the access to medicines arena to highlight to the citizens of different countries how much their governments are actually paying for these medicines, how much these medicines are really costing their country. There's also potentially a role for joint price negotiations. So joint price negotiations are where different countries form a single sort of negotiating bloc, a single entity with which they then negotiate for a particular drug with different drug companies. So one example of this is the Benelux collaboration. This is a collaboration between Belgium, the Netherlands, Luxembourg, and Austria. And they negotiate, again, as a single entity with drug companies for individual drugs. And there may well be a role for these joint price negotiations in improving the price that countries can get medicines for, which will obviously improve access and will improve the situation for their health systems. The other area of transparency is the transparency around the price of research and development. So as I kind of touched on earlier, there is essentially no transparency on what the average cost of researching and developing a medicine actually is. Pharma have not released these figures. What they have released are pharma-sponsored studies that provide estimates of how much they argue it costs to research and develop a drug. However, quite apart from being pharma-sponsored, these studies have been criticized for vastly overestimating the likely price of R&D. They all rely on quite a lengthy string of very dodgy and dubious assumptions, as well as some seemingly quite arbitrary increases in the estimate. And independent studies, for example, by the Drugs for Neglected Diseases Initiative, which is a really great non-profit biomedical research and development body, have come up with estimates that are around 10 times lower than the official pharma estimates. So a common figure that's thrown around by the pharma industry and unfortunately has been taken up fairly uncritically by most of the media is that it costs around $1 billion to $2 billion to research and develop a medicine on average. But independent estimates, for example by DNDi, based on their own experience, have found that it probably costs more like $100 to $150 million to produce a medicine. Some estimates have been even lower, around 50 million. So 10 times lower than the official estimate. However, again, the problem here is that all of these are essentially estimates because we simply don't know how much it costs to research and develop a medicine. And this lack of transparency and the dubious estimates that are put out by the pharmaceutical industry are intentional because they allow the industry to legitimize the excessive prices that we pay. So we need to push for more transparency on how much it costs to research and develop a drug, and we need transparency on the price of R&D to be, again, a condition of receiving public money. Another aspect of transparency is transparency around the funding of R&D. So surprisingly, there's very little transparency on who is actually funding particular research and development studies for new medicines. We know that overall, a large proportion of overall research is funded by public money as well as by charitable money, but we don't know which individual studies are, and we frequently don't know how much of a given individual study receives public money. And this is quite important for advocacy because the critical argument that we make is that publicly funded research must produce public goods. However, this is a much more difficult argument to make if we don't know which studies were actually financed by public money. We just know that a lot of them are. So we need more transparency in this topic so that we can push more effectively for access to medicines. And then finally in transparency is transparency around clinical trials. So this is a topic that's received quite a lot of attention. There's been various sort of higher profile people who have advocated for this. Ben Goldacre is quite a well-known example of someone who is quite active in this field. The crux of this issue is that trials of new medicines that find no improvement over the existing and generally cheaper medicines on the market are significantly less likely to be published. So if I do a research trial into a new medicine and I find that that new medicine is more effective than the existing medicines, it's pretty likely that that study is going to be published. However, if my trial finds that there is no improvement over existing medicines, or even that this new medicine is worse than what we already have, it's significantly more likely that that study will just not be published at all, so it won't be visible. And this is a really massive issue, because it means that the data that we have that says that new medicines are better than the existing medicines may simply be not valid, it may not be reliable. And so nations may well be paying more for newer, more expensive medicines that are not necessarily more effective based on misleading data. And you can see the effect that would have on access to medicines and on the healthcare systems as a whole in different countries. But all of these solutions, although very important, are all essentially treating the symptom rather than the cause. And the cause, as I like to keep saying, is the fact that the R&D system as it currently stands is not fit for purpose. So what we need to be thinking about in the long term, in the broader sense, is pushing for an alternative R&D system, one that is not focused around profit, but one that is focused around patients. Now this is a very big topic, and I'm not going to go into too much depth over it because it would probably take a much longer presentation. But there have been various different conversations that have been going on around these topics. So people have been pushing for the establishment of progressive global principles for research and development, the establishment of a global pooled fund for R&D, and the establishment of alternative funding mechanisms for R&D that de-link the price of medicines from the cost of research and development. And that last idea, de-linkage, is a really important idea, and it's one that's been gaining quite a bit of traction recently. Quite excitingly, the recent United Nations High-Level Panel on Access to Medicines, or the UNHLP on Access to Medicines, acknowledged really for the first time that de-linkage was an important topic that needed to be considered in how we are going to address the flaws that exist within the current system. Now that paper, that report, proposed de-linkage as an addition to the current system. We would view it more as an alternative. But the fact that it is being discussed at this level is quite an encouraging sign. The actual mechanism for de-linkage, I'll have to talk about in the questions, but I'm not going to go into too much depth on now just because I'm probably running out of time. But if you are interested in these sort of alternative biomedical funding mechanisms, in this idea of an alternative system for conducting research and development, I'm slightly biased, but I would encourage you to go and look at UAIM's ReRoute report. This was a report that mapped out all of the kind of different existing and proposed systems by which we could develop an alternative R&D system, and it's quite a good way to get a primer on that issue. Now I'll just finish by plugging again the fact that UAIM will shortly be releasing our global charter for the advancement of equitable biomedical research and development, or the R&D Charter for short. This is a document that essentially sets out our vision for what, and the vision of many of our allies in the access community, for what an equitable and effective R&D system should look like and what we should be striving to achieve. And we'll be asking different publicly funded research bodies to sign on to this charter. So I'll finish there. Thank you very much. And if you have any questions, you can either ask me now or that's my email. Thank you.
I'd like to say a couple of words. I fully agree with what has been said. I'd like to add a couple of things though. The first one is that the issue of drugs, the cost of drugs, was made worse by the neoliberalist victory, because the main problem comes from the U.S., because the price is fixed in the U.S. and Republican presidents, starting with Ronald Reagan, and sponsored by pharmaceutical companies, banned all laws enabling the U.S. government to have some control on the costs of drugs. This means that in the U.S., companies are free to fix their prices, and the government cannot intervene. In our country, these drugs account for 60% of the market. Therefore, this is how the price is fixed is very important. For instance, Novartis and Roche, the two large Swiss monopolies, have invested a lot of money in the lobbying activity towards the U.S. government. So you see how the two things are clearly linked. Then price recommendations are made by, for instance, by people, the kind of Mr. Stiglitz, who said that the current situation is not sustainable, and he proposed to abolish the patent principle, and the fact that clinical trials should be funded mainly by with public money and not by the pharmaceutical industry. And last point is that proving that the price does not mirror the true cost of research. You have two examples here. Thalidomide example. Nobody wanted that drug anymore. Its cost was zero because it cost zero to manufacture that drug. Then someone discovered that that drug was useful to treat some sort of a form of cancer. So we had that drug back, and they made a monopoly, set up a monopoly. So this drug costs over 300,000, and it's very expensive now. The other thing is that it's not just new drugs that are so expensive, but also old drugs that we still use today are produced by one single company, which means that their prices have increased up to 1,000 times. You might remember that American guy who went to jail because he increased the price of medicine by 5,000 times. He also was accused of tax fraud, by the way. But this shows that more and more often these drugs are produced by one single company, leading to a unsustainable situation whereby either they're not produced anymore, forcing us to use the new ones, or they cost up to 1,000% more than what they used to cost before. Thank you. So I think that we can round off this session. I want to thank the two speakers, and I want to conclude with the words of an oncologist who told me this some time ago. He treated leukemia in children, and he was involved. You might remember the Keta case. Keta was the name of the child who was treated with the Dibella treatment, alternative treatment, and she died sometime later. And there was a long debate on TV, on Italian TV, and this professor, this oncology, joined the debate, and he told me that we have a 70% survival rate for these kinds of cancers. It's not that new drugs have been invented, but we have learned how to use the old ones better. So this opens up a debate on the worth of drugs. We want to impose the use value, meaning that we're ready, we're prepared to pay for drugs if they improve quality of life. We don't want to pay for drugs if they're not effective. But let me tell you something else. There's another example. There's a flu river blindness that was treated until some time ago, which was not effective, and it even had side effects for 10% of patients. Then eflornithine was invented, a new drug, much more efficient, much more effective, and with no side effects. And this drug was produced up to 1995, and since this drug was also effective for a neglected disease, it was not produced anymore. This was also the case in our country. You might remember the director of the Cancer Institute in Aviano, who was once said on TV that many effective drugs disappeared, which is not profitable to produce anymore for the pharma company. And this was the case for this fornitine drug, which was, its production was discontinued. But then it was resumed. Why? Because it turned out it was very effective to treat hairs, to get rid of hairs. So you can see this is an example of how interests and lifestyles of the rich world affect the way that we act to relieve human suffering. So again, we must go back to basis, which means privileging usage value and not trade value. Therefore, making null all rules allowing big pharma to have so much power and margin, and as we will see when the GOTA will meet at the G7, liberalism, Milton Friedman's school was attacked on the issue of drugs with the Bayh-Dole Act. The Bayh-Dole Act was passed in the 80s, and the Reagan administration passed very quickly. Now, what's this act purpose? This act allowed for the privatization of an idea, which means that researchers receiving public money to perform their research, if they came to a positive outcome, they could patent that with their names, and then sell them to the pharmaceutical industry. Now, this allowed the pharma industry to cut research costs. Of course, out of 1,000 molecules, eventually just one reaches the process. So, which means this has always been the case for the pharmaceutical industry. The pharma industry has always stated that research costs were so expensive. But the Bayh-Dole Act allowed for a situation whereby, for a so-called for the cherry picking, exploiting one molecule and not investing a single dollar on other research and development exploiting public money. This is going back to capitalism for production and affecting, of course, our health, which I want to stress is a constitutional right, which cannot be considered as good.